Our aim is to highlight irrigation fluid extravagation as a cause of extrathoracic airway obstruction. There are two cases of around 60 years old male and female of normal BMI who underwent arthroscopic repair of rotator cuff tear under general anesthesia with LMA and having one had right selective upper trunk block and the other had left shoulder anterior capsular block. The procedure lasted for both for about 4 to 5 hours, and the irrigation fluid used was about 25 to 36 liters. Intraoperatively, swelling was observed along the ipsilateral neck and chest, then subsequently on the contralateral side at the end of the procedure, along with rising peak airway pressures and reduced tidal volume despite unchanged ventilatory settings. In these pictures, we can see the swellings. Hemodynamic parameters remain stable throughout the procedure while airway pressures remain within normal limits at the beginning, but as the surgery progressed and operative time increased, the airway pressure gradually rose above the baseline values. The flow volume loop demonstrate inspiratory flow limitation suggestive of extrathoracic airway obstruction at the beginning, and then subsequently it may lead to intrathoracic airway obstruction consistent with airway compromise secondary to irrigation fluid extravagation. For these patients, as the patients are usually covered in drapes and the presence of surgeon at the head end makes early physical detection difficult. This makes vigilant monitoring of flow volume loops and airway pressure of paramount importance. In such scenarios, what we have to do is we have to stop the surgery and irrigation immediately. The patient should not be extubated. If in case they are extubated, they should be re-intubated with difficult airway cart ready. Supportive measures include limiting IV fluids, administering diuretics, and monitoring urine output and hemodynamics. We need to observe the patient for 12 to 48 hours and repeat complete tests before extubation and extubate after swelling subsides. Both patients were successfully extubated after resolution of airway edema. The conclusion is during prolonged duration of surgery of arthroscopic, increased volume of irrigation fluids pose a risk for extrathoracic airway obstruction. Vigilant intraoperative monitoring, early recognition, and timely airway management are crucial to prevent catastrophic airway compromise.